Hey, welcome back. Today's the fifth and final session of our series. Yes, we are almost at the finish line. Today, we'll talk about the conclusions of the study, how the results relate to the overall message these investigators are trying to tell us, and what it means for the greater medical community. So, in other words, what does it all mean, right? Remember how the results relate to the overall message these investigators are trying to tell us, and what this study eventually means for the greater medical community. So here we go. So remember this quote from a previous session. Let's just keep this theme handy today because we need to be both birds and frogs. All right, so here's a study again. They investigated the results of children with recurrent acute otitis media, or in other words, ear infections that keep happening again and again over time. And they took this group of children, randomized them into the medical management group or tympanostomy group. And from the abstract of the article, we can see that their primary outcome measure was the rate of infection episodes after treatment for the 2-year follow-up period. And so why? Why did they do this study and why did they even design it the way they did? Well, the intro told us that there's a lack of consensus in the medical community, most notably in the pediatrics and ENT communities as to what the best route of treatment should be. And another important point that they wanted to investigate was what the results would be after 2 years of follow up, because most of the previous studies in the literature had shorter follow up periods. And along with the primary outcome measure, they also tested a handful of secondary outcome measures, as you can see there. And they received results in Table 2. Remember what Table 1 and Table 2 usually depict in studies, right? And this graphic now shows all of the main results. And here's a table we made to record all the outcomes, and we highlighted all the significant outcomes. So what is this telling us? Well, let's remember that only the results highlighted in yellow were statistically significant. So the primary outcome measure, the rate of post-treatment episodes, or AOM episode rate, as you can see on the first line, did not see a significant difference in treatment outcomes. And this, in fact, is what they state in the discussion on page 1798 at the bottom there. And as for the secondary outcomes, the only ones that do have a significant difference between groups are the percentage of children with treatment failure, the time to first episode of AOM, and the days with tube otorrhea or antibiotics. Okay, now let's pause. And as for the last outcome measure, let's talk about this. So at first you'd think, well, of course the medical management group had more antibiotics. It was the medical management group. But remember this, only during the 2-year follow-up period. This is what the results mean. It should not count the treatment itself, okay? But the first part of this outcome measure, the number of days with otorrhea, well, this would be obvious, and I'll tell you why. Let me explain it a little bit. So you know what otorrhea is again, right? It means drainage from the ear. And if children who had tubes placed now have what you can think of as kind of like a drain that stays there and it drains any fluid that builds up in the middle ear. So you and I can have fluid in our middle ear all the time without an infection. What makes it infected is the stasis, or rather the fluid that just sits there building up without any drainage. And the stasis of that fluid in that space invites bacteria to prosper and grow. And this happens more often in children because the eustachian tubes, those tubes that drain the fluid buildup back down into the nasal passages, they're more horizontal in children than in adults. So there's a higher risk of fluid stasis or buildup, and it's more prone to infection. So that's why children get more ear infections than adults do. But if there's a tympanostomy tube placed in the eardrum or tympanic membrane, then the fluid drains out whenever it needs to, and it won't get infected. But this is why the tympanostomy group has a higher result here. Not sure if you remember me stating that in the previous session, that it doesn't say if the otorrhea is purulent or infected rather, or clear, which would be non-infected. So we must just assume that it's any kind of fluid. And the other outcome measure having found a big difference was the number who had treatment failure. But remember that a decision by the parent, and this was mentioned previously in the study, regardless of how the study was going, to switch to the other group was deemed a treatment failure. So all those parents whose children were actually randomized to the medical management group, but they decided to have their children get surgery instead because they empirically hoped this option would be better. These are children who are deemed as having treatment failure. Was it really a failure? Not really. It was mostly a failure of the parents to stick with the randomization is what it was. But I can tell you this, there's nobody more desperate than a sleep-deprived young parent. I have been there. But let's continue on. But this is just something to note. So as you can see, we're looking at these results. We're really deciphering them. We're trying to dig deep into what they mean. So this is the point at which we're being frogs. We're getting deep into the details in the mud so that we can pull out and get the true meaning of this. All right, so let's come up for air and ask ourselves, what does it mean? And what do the authors think it means? What is their overall conclusion? Do they stick with the study population or do they overstate the results? Well, they really seem to stick with the study population, and they accurately state that for this particular population, there is no significant difference, as you can see there. One notable detail they did mention, however, I thought this was really interesting. It's not statistically significant, but it's the results seem to be worse across the board for the younger children than the older children. And we can see that here in the results section, table 2. This particular, there is much larger advantage of tympanostomy in the first year, as you can see, but then it tips to the advantage of antibiotics just slightly in the second year. You see that? So that was one of the micro results we can kind of take away from this too. Now, does that mean we can infer that children who are, let's say, 4 years old would do better with antibiotics than with tympanostomy? No, not at all. Why? Because this study did not investigate children of that age group. So we can't over extrapolate those results, you see? And that's an important point because the conclusions of some studies do try to do that, and they really shouldn't. So they did discuss their strengths and limitations of the study at the end, but they did not discuss how to proceed forward with this information. And one detail I'd probably like to see if I were a provider interested in this information for the sake of my patients is, well, what's next, right? I mean, what do these investigators think can or should be done next? What about studies with older children or just widening the age window in order to see if the improvement continues with age over this follow-up period? What about more studies like this with a larger N? Or in other words, like a larger number of study subjects so they can get a high enough statistical power to get some really robust, statistically significant results? Because a lot of this was insignificant statistically. Perhaps that might require an even larger, nationally based multi-center study over a longer time period. And I'm sure there's more, but these are just examples of possibilities of the future of this study subject. So that wraps up this session, and it wraps up the series. So that's it. Nice work. You did it. Thanks for sticking with me. I hope you learned a lot through this process of going through the paper together this summer. If you are looking for more of this, and you're looking for the opportunity to be in a cohort where you can do this yourself and learn from each other, then our journal club really is for you. And the fall session will be starting in September. So be sure to be on the lookout from the pre-med scene on when registration opens up. And I'd really love to see you there. And whether or not you do join our fall journal club, I hope this seminar series has helped you. And I wish you a good, productive, and enjoyable fall semester. Keep subscribing to our YouTube channel in either case and our website because the pre-med scene continues to have some really great resources for all of us going into medicine. And I know for a fact that they have some terrific programs coming in the near future. So as always, feel free to reach out to me and enjoy the rest of your summer.